The Reza loves Robbie. Robbie loves Reza. Happy Friday, y'all. It's the OG version, RLR. Once a month, Prof Rez treats us to his presence on these Friday VMRs. But that's you guys. I get to hang out with Prof Rez every day, so ramp up your game. If you want his personal cell phone number, it's actually very, very easy to find. All you have to do is subscribe to rlrcpsolvers.com and listen to any episode. By minute 5, I guarantee you will have his personal cell phone number, and it's not fake. It's actually real. Any comments, Prof. Rez, before I before I hand the mic to other
I'm
people?
about to share them your number, but I don't have it from memory.
Don't worry, Prof. Rez. You can share my number, but I have such a strong do not disturb filter that nobody comes through. Um, Anyway, so feel free to share it anytime, anywhere. It doesn't matter. What matters is we're in for a treat today. It's an all internal affair, and why don't I start by thanking the folks who are um, who are making this happen, starting with our scribe. And I feel like Prof. Rez should introduce our scribe, given their evolving, wonderful relationship beginning on Wednesday. Prof. Rez, Kevin is in the lukewarm seat again. What words do you have to say about Kevin?
Oh man, so I haven't been canceled yet. Hi, Kevin Muller. How are you?
I'm doing very good. I'm very excited for the session today,
You
and
have any
learn a
football
lot
planned
with
for
you
this
guys.
weekend?
Huh?
Do you have football planned for this weekend?
No, I actually don't, but it's due to the fact that I actually had surgery last week on my
Ooh.
nose.
Oh
That's why I have to
man,
recover a little.
are you okay?
Yeah, it's just a septum deviation, but it's not
Gotcha.
stopping me from scribing here. So you see the you see the dedication?
Yo, Robin, you got us all injured working for you, man. What hold do you have on us?
Oh, Prof. I was talking about engine. Manaswini is doing teaching points today, and I feel like maybe to belabor the intros today, Manaswini has been crushing it. She's one of our newest 2026 VMR leaders. If there isn't 3 rapid fires led by Manaswini in the quick scroll that I look for on the CP Solver schedule, there's something wrong. So, Manaswini, mic to you. Maybe you can say hi to folks, and then we can introduce our case presented.
Hello everyone, I'm Manaswini. So excited to be here, and it's the first session in 2026 with Prof. Rez and Dr. Ravi, where two forces unite. So it's going to be explosive, so excited, and also for Lorenzo's case.
I feel like Prof. Rez is inclined to jump in to tell you why it didn't happen last month, and the reason is me because I completely messed up the scheduling. But I'm glad we get to celebrate 2026, starting off with the Lorenzo case. Lorenzo, I'm very, very excited. I think every time you uh, make an impact in the space, it leaves a mark on me. I hope the diagnosis is simpler than paraneoplastic GCA from a myeloid neoplasm today, but knowing you, I don't know. Mike to you, my friend.
Hello, everyone. My name is Lorenzo Garcia. I'm an internal medicine resident. I'm sorry if I look a little bit sleepy. I was on call on doing night shift, so I'm sorry if I'm not pronouncing words very well. So nice to meet you, Prof. Rez. And we joked about you in the my first session where I said you were way better than me in golf. Would like to play you someday in the future, and
Oh,
I hope you will
Lorenzo,
like the case as well.
I would be the honor of my life, man. Thank you for
So whenever we can get started, I will start with the first aliquot. Okay, so I have a case from a patient that I saw around last July from 2025, and I have the case divided in about 6 aliquots, with the sixth and final aliquot revealing the diagnosis. We'll start with a 47-year-old female that presented to the ED with a 4-day history of nausea, vomiting, non-sanguinolent diarrhea, and subjective fevers. She denies chest or abdominal pain, cough, unintentional weight loss, night sweats, urinary symptoms, or a new onset skin rash. In terms of past medical history, she has hypertension with retinopathy, nephropathy, and LVH. He has a monoclonal gammopathy of unknown significance, IgA lambda, on surveillance, and she has terminal CKD secondary to the hypertension. She was transplanted in 2021, which has been complicated with post-transplant diabetes, an antibody-mediated rejection in February 2025, treated with plasmapheresis, immunoglobulin injections, and rituximab, and she had another antibody-mediated rejection and a borderline cellular rejection in May 2025, for which there was no increase in immunosuppression due to a concurrent and probable diverticulitis and pancytopenia. She has a kidney graft dysfunction, chronic, with a baseline creatinine of around 4 milligrams per deciliter. And she also has a possible neoproliferative lesion in the ascending colon detected in February 2025, for which she underwent a colonoscopy that was normal and the biopsies were negative for cancer. In terms of family history, it's non-relevant. In terms of social history, she was born in Uganda and she's been living in Portugal since 2011. She lives with her husband and 4 children. No history of recent travels or pets, and she is unemployed. In terms of medication, she takes tacrolimus, mycophenolate, prednisone, carvedilol, prophylactic valganciclovir, darbepoetin, 50 micrograms per week, insulin, and she has no allergies to medication. And I will stop here.
Wow. I feel like we're solving an AHM CPC right now, Rabih. A lot to dissect here. But I'm just going to share my brief thoughts and then pass the mic to you to layer on your wisdom, RG. And for me, I think the mistake would be to anchor on all the complicated past medical history at this point in the case discussion. That is to say, of course, patients who have transplants, they're on immunosuppressive therapy, no doubt they're at risk of complications, and no doubt this will broaden the infectious and cancerous possibilities, but they're also at risk of common things. And so if you try to reach for rare at the start, you're going to be over testing this patient. You're going to be over proceduralizing this patient. So you have to show restraint. And I know we're in a VMR setting, and usually the diagnosis ends up being something exotic, but it's important to practice those muscles like you would do in real life. And so when I get all this information, I'm just lumping all of that past medical history into a patient with a transplant on immunosuppressive therapy. And maybe later I'll be more specific with what type of immunosuppressive therapy, because that might affect which arm of the immune system may be down. And I'm really just focusing on the chief concern and treating this patient like I would any other patient at the start of the encounter, but being ready to broaden my workup if things don't go as expected. And so what do we have at the start of the encounter? What we have at the start of the encounter is a syndrome that seems to be heavy in the gastrointestinal tract, and the tempo is acute. So I would say this is a 47-year-old woman with acute onset nausea, vomiting, diarrhea, and fevers. And with regard to the fevers, I'm already priming my mind that even if I don't see it in the physical exam, because they're immunosuppressed, I'm not going to lower the possibility of an inflammatory process. And when we're talking acute and onset, all our focus will be infection at this junction. And for infectious diarrhea, most often you won't even isolate an organism, and most often patients won't even come to the emergency department. And the real question becomes, is this some kind of virus that we'll never isolate? Is this some kind of bacteria that will self-resolve and doesn't need antibiotics? Or is this going to be something much more significant than that? And, if a patient feels sick enough to come to the emergency department with diarrhea and fevers, generally they'll get antibiotics. And you have to just be cautious, though it's very, very, very unlikely that you're not dealing with a strain of an organism in the E. coli family that can maybe propagate something like hemolytic uremic syndrome. So, Rabih, I'll give you the mic. I know there's a lot of information here. I'm just trying really hard not to get bogged down and trying to chase these threads with no reason yet. Now, maybe later they all become relevant, but for me, it's just a woman who's immunosuppressed here with acute onset inflammatory diarrhea, most likely infectious in origin, and most likely will resolve on its own. I can't hear you, but I can see your mouth move.
Oh, I was just doing this, Prophet. I was just saying, all of us are stressed, Prophet, thinking about this problem, but none of us have to describe it like Kevin. So kudos to you, Kevin. I also see Lyra's fingers typing ferociously, so I'm conjecturing that there's some support from the team, which is awesome. Uh, Prof. Rez, I think my only contribution is to give you some numbers that are my best guess. 100% of acute diarrhea is a routine infection plus meds. 98%, sorry, I should say, I'm going to take it back. 100% of acute diarrhea in an immunocompetent host is acute infections, viruses, and bacteria, or meds. 100%. 98% of diarrhea in an immunocompromised host is the same differential diagnosis. Do not waste your energy on the 2% unless, one, the patient is critically ill, or two, the problem evolves beyond acute diarrhea to feature hemolytic anemia and kidney injury, typical H2S, or to feature pancytopenia and lung infiltrates. So the host rarely influences the differential diagnosis of a common problem. So you found a common problem. The host does not change the calculus for a common problem. So the only time you have to use the host to solve anything in clinical reasoning is when the patient is too sick that even the 2% matters, or that you actually realize that what is common is actually not common. Acute diarrhea featuring hemolytic anemia and kidney injury is not common at all. So I'm right there with you, taking it easy. So far, I have no reason to factor in the host status. And we'll see if they're critically ill or the problem evolves. Lorenzo, mic to you, my friend. I know one of those two things is going to happen. So the question is when.
Well then, for aliquot 2, on admission, the patient had a BP of 97/65 and a heart rate of 92, an SpO2 of 97% on room air, and a temperature of 35.5 degrees Celsius. On general examination, he looked ill and uncomfortable. He had pale and dehydrated mucosa. No GVD or peripheral edema was noted. In terms of cardiovascular and pulmonary exam, it was within normal limits. His upper abdomen was soft and generalized, and had generalized tenderness on palpation, no masses, organomegaly, no signs of peritoneal irritation, and had a negative Murphy sign. We did an ABG on room air, which showed a pH of 7.35, a PCO2 of 19.4, a PO2 of 84.4, a bicarbonate of 10.9, a lactate of 0.8, a sodium of 118, a potassium of 4.9, a calcium of 1.29, a glucose of 329, and a hemoglobin of 8.8. I will also give you her initial labs. She had an hemoglobin of 9.2. Previously, she had 12.6 in June of 2025. A leukocyte count of 2,390. Previously, it was around the same value, with 1,700 neutrophils. She had a platelet count of 139,000, a BUN of 240, a creatinine of around 14, previously 3.27, a total bilirubin count of 2.90, with a direct bilirubin of 0.38, an AST of 54, an ALT of 7, a GGT of 132, an ALK Phos of 1,366, previously 131 in February, an LDH of 2,418, previously 281, and her ions were basically the same as in the ABG. She had a CRP of 219, and I'll stop there.
The problem has become both more severe and not so common at the same time. And Prof. Rez, maybe what I can try to offer as folks is a crack at trying to stabilize this patient and what we might do quickly, and I maybe pass the mic to you to see how you're thinking about it and how you push the case forward, because the patient is definitely unstable. And I think there's two key elements for us to analyze, which is her acidosis and her hypovolemia. And I think with her being hypovolemic to this degree, she will certainly benefit from fluid support. And the question is, what fluid do we use? And usually this is an artificial exercise. It doesn't matter. But when somebody is this acidotic, remember that normal saline, by bringing in the chloride, will force out bicarb, making your patient even more acidotic. So this is a patient where I would probably be giving her lactated ringers. What would my goal be? My goal would be to improvement of her blood pressure and perfusion markers, and then my hope would be that that helps with some of her kidney dysfunction. Even though it's hard to imagine that all of this kidney dysfunction is accounted by a component of hypovolemia. So I think giving her fluid support is going to be key. It would be a difficult decision whether or not to give her broad spectrum antibiotics, because technically, with her being hypothermic and leukopenic, she meets surge criteria. And I think that when you think about SIRS criteria, the specificity for infection for SIRS is pretty low, and the sensitivity is decently high. But when you factor in SIRS criteria and immunocompromised host, I think I would probably have a very low threshold to give her antibiotics, and it would depend, quite honestly, on something that is impossible to capture on VMR, which is her degree of how she looks. But her numbers are so abysmal that I think I'm much more likely to be filled with regret at not treating her with antibiotics than to be filled with pride that I was precise in my initial treatments. And so I would probably give her broad gram-positive coverage with something like vancomycin, and then broad gram-negative coverage with something like cefepime or ertapenem, knowing that she's likely hospitalized. I'd probably add on anaerobic coverage too, since she has a nidus of vulnerability in her GI tract with a colonic mass process of unclear etiology. And then I think the acidosis is really, really interesting because, as we talked about on yesterday's VMR, the only form of anion gap metabolic acidosis that you can rapidly correct is ketones. So I would definitely be giving her insulin, not with the hopes of making her sugar prettier. A 300 is not significant, but in the hopes that a component of her anion gap metabolic acidosis is from ketones, and perhaps I can make her pH prettier. The real decision for a patient like this is she meeting dialysis criteria? And dialysis criteria is probably best captured by the AEIOU mnemonic. A is for acidosis, E is for electrolytes, specifically hyperkalemia, I is for ingestions and toxins like metformin, O is for volume overload, and U is for uremia. And here, the major issue is the A, the acidosis. And the only time dialysis is of value is when somebody has an acidosis refractory to medical treatment and medical intervention. So this would be a conversation with nephrology about whether that's the case. And I think that the threshold to initiate renal replacement therapy is appropriately high, because it actually, when you dialyze somebody, worsens their renal prognosis. By taking over the kidney yourself and letting the kidney go to sleep, it can hibernate for a long, long, long time. So you'll notice there's a reluctance to initiate dialysis unless it's absolutely necessary, because the more perfusion the kidney gets, the better for it in general. And so you might try to see if you can fix the ketosis. And then your hope would be that a component of her anion gap metabolic acidosis is from the kidney dysfunction itself. And that potentially you can do something about, which I'll pass the mic to Prof. Rez to sort of think through what might be happening in this case.
Rabih, I think that's phenomenal. And because you already take care of the management aspects of this case, I'll just focus on the diagnostic aspects. And when you look at all this laboratory data, there's really two laboratory data that really grab our attention. One is the LDH, and you can see it's not only red, but it's bolded red, which tells you the significance of it. And the other is the alkaline phosphatase, which is 1600. So from a diagnostic lens, those are the two numbers I will be trying to explain. I saw the CRP. It just says this patient's inflamed. I put it to rest. I saw the hemoglobin of 9.2, which is a significant drop from their baseline. And I thought, well, could there be a hemolytic component? That's a possibility. And I would send a haptoglobin. I would get a peripheral blood smear, but I'm totally fine explaining the drop in hemoglobin from the impaired kidney function that this patient has. But you still got to figure out if this is hemolytic or not. So now you look at the LDH. At the end of today's case, we have to explain that LDH. And this is where I bring the past medical history to the front of my mind or to the foreground, where I say, okay, she's immunocompromised. She has a history of transplant. So now there are certain diagnoses I have to consider. And Rabih, I think we have to just be open to the possibility that multiple things can be going on. For example, it could be that diarrhea is infectious because she's immunocompromised, prompting her to come to the emergency department. And then we find all these other data points that was something brewing in the background, but it didn't reach that threshold for the patient to actually come and have test results done. So when the LDH is that high, the first step you stop is you say, oh, could this all be hemolysis? And we'll send the haptoglobin, the peripheral smear. I don't think it is, but we'll send those tests. Then for this patient, I'm going to bypass our pyramid where we have infarction of tissue, and I'm going to go straight to malignancy. Because something that you have to be worried about in someone who gets transplanted is post-transplant lymphoproliferative disorders. These are opportunistic cancers that can manifest in such hosts. And so you say, okay, could that be malignancy? And can that explain the ALK phos? When you have an ALK phos of 1600, the question becomes, is it something infiltrating the hepatobiliary system, or is it bone? And yeah, we have a GGT right here, and the GGT is 132. And we do have an indirect hyperbilirubinemia. Yes, I will definitely get an ultrasound or a CT scan to evaluate the biliary system, but I still think there might be a disproportionate between the GGT and the ALK phos, where it might not be completely explained with what's happening in the hepatic parenchyma, and we're going a little further out of the hepatic parenchyma. So sorry about that, folks. So to summarize, we have a really high LDH. It's probably telling us cells are turning over. The next question becomes, is this some kind of malignancy, specifically lymphoma? And the LDH is a marker of that lymphoma. And lymphoma likes to infiltrate. We have an elevated ALK phos. The GGT confirms that stuff is happening in the liver. So then we're going to go towards the liver to see if there's something infiltrating there. And when we get the imaging, if there is no biliary dilatation, it doesn't mean that you can't be having lymphoma or some substance obstructing the intrahepatic biliary caniculi. And so even if the MRCP, for example, is negative, I would still proceed with a potential sample of the liver tissue. But before I do any of that, honestly, I would pan scan this patient. This patient with that LDH, haptoglobin, peripheral smear, cross-sectional imaging, chest, abdomen, and pelvis. I'm going to be looking for a site that might be easy to access. If there's nothing, a lymph node, etc., then my focus is the liver, and it would prompt me to get an MRCP if such resources are available at your institution, because reflexively, this is just looking like someone with a lot of cell turnover after a transplant, and something's really invading that hepatobiliary system. And with the indirect hyperbilirubinemia, like we already said, we're going to be open to the possibility of a concomitant hemolytic process. That was a lot. Let me see if Rabih has anything to reflect on before we move on to the next aliquot of information.
Caniculi. Canicula. That's all I can think about right now. Caniculi. Oof, wow. I think you're right. I think it's a caniculi issue. That's all I have to say. But I completely agree. I think you have to clarify this problem a lot more. And it really is looking like there's something taking up space and bursting. And we just had an academy session on that, on a case that Pranay presented, Prof. Rez, and just came to realize that like we overthink these kind of space occupying bursting things. They ultimately need a pathologist. And I think we're heading in that direction. So you can't do pathology without radiology. And so for me, I'm really, really intrigued to see what the imaging shows to clarify.
Rabih, that's the kind of statements I want you to put in the book. You can't do pathology.
Wait, hold on, Prof. What book are you talking about, Prof?
Rabih and I are writing a book, shameless plug number 2, but really write that sentence down. That has to make its way into the book.
Aye, Captain. All right, Renzo,
Wonderful
Mike to you, my
discussion.
friend.
Wonderful discussion. So, in terms of what we have in aliquot 3, due to a concern of a possible very aggressive infection, most likely cholangitis, or the top contender was cholangitis, we did an urgent CT scan of her abdomen and pelvis, which showed hepatomegaly, splenomegaly, a kidney graft in the right lower quadrant, a discrete terminal ileal distension, and a distended appendix in continuity with extensive heterogeneous colic wall thickening, with contrast enhancement and surrounding fat stranding, worsened in comparison to the last scan in May 2025, of possible neoplastic origin. We did a UA, which was innocent, with a negative urine culture. Due to the worsening kidney function, the patient was started on hemodialysis. And in light of the intense inflammatory response and possible intra-abdominal infection, the patient was started on empirical Zosyn. We also collected blood cultures ×2, which were positive for E. coli, sensitive to Zosyn, cefotaxime, and gentamicin. Additionally, assuming that the patient could have a component of adrenal failure, the patient was started on fluid therapy and increased dose of prednisone. We suspended the mycophenolate and maintained treatment with tacrolimus. And I'll stop here.
I felt like I talked a lot, Robbie. I want to pass the mic to you, but I just have one question for Lorenzo. Lorenzo, was there any biliary dilatation on that CT scan?
No.
Okay. All right, Robbie, mic is yours, my friend.
It was amazing. I was going to ask the exact same question, and we find ourselves with an intriguing dilemma, Prof. Rez, which is that we have a convenient kind of reflex answer for the LDH. And when you are looking for an LDH and you get a hepatosplenomegaly on the CT scan, you're satisfied. You're like, I think I can merge those things. I think it's interesting to see what imaging correlate we have for the ALK-Phos. Because as you said, you were expecting canicular issues or bile disease issues, and yet you have the whole liver involved. And so what the significance of that I find very, very interesting. And I think it's hard not to reflect on, I think the most daunting finding, which is that you have E. coli bacteremia. And I think this is where I think what everyone is doing here is really just a powerful illustration of the next level thinking, because I think it's very reasonable, and it probably would happen in many hospitals in the United States where you find E. coli bacteremia, you're like, my job is done. Patient came in with only 4 days of symptoms. I found a 4-day-old disease, coli bacteremia, and I'm going to treat this patient and then let everybody else figure it out. The answer to that is don't do that. Why? E. coli bacteremia does not cause an LDH of 2000. This patient is presenting with pseudo-acute disease, meaning that she's suffering a hyperacute complication of something that is rapidly progressive. And it would be a mistake to focus on the E. coli bacteremia. But let's not forget what value it gives us. It gives us the idea now that even though her GI tract has not had a macroscopic hole in it, it likely has a microscopic hole in it. And I think the significance of that cannot be underweighed. And so let me try to take a moment to make the best argument I can for that, and then pass the mic to Prof. Rez to see how he's thinking about the liver and the spleen, especially in the context of the labs you were thinking about, Prof. Rez. So GNRs come from the inside of the body that is still exposed to the outside. And to understand that, you really have to realize that the body is a donut. The skin is not the only part of the body that's exposed to the outside world. All our insides have an outside, the GI tract, the GU tract, the GYN tract. And the skin happens to be colonized with gram-positive organisms, but the outside of our insides are colonized by gram-negatives. And so in this patient, she has no gynecological symptoms, which is a very powerful predictor against a gynecological source of gram-negative broad bacteremia. Her UA is, quote, innocent, which I love. And so the probability of her having a urinary source is very, very minimal. And so what are you left with? You're left with GI disease, and you have gastrointestinal symptoms. You have a nidus of vulnerability in her GI tract, and you have no other reason to suspect the E. coli came from anywhere else. So would you be happy to say that this bacteremia from E. coli is simply because of an acute infectious gastroenteritis? The answer to that is no. It is exceptionally unusual to have bacteremia from infectious gastroenteritis unless you have a food-borne organism. Why is that true? Foodborne organisms live in food, not in our bellies, and our bellies are not used to fighting back against them, which is why the rate of Salmonella typhi bacteremia is pretty high, which is why the rate of Campylobacter bacteremia is high, which is why the rate of Shigella bacteremia is high, but not organisms that live on your own body. Her immune system should crush E. coli, and it's not. And so the question is it because of the mycophenolate, the tacrolimus? And the answer is possibly. But gastrointestinal sources of bacteremia are equally likely to be from a structural issue rather than a systemic medication effect. That is also true for the gynecological tract and for the genitourinary tract. Patients get bacteremic from the insides, less commonly because of systemic immunosuppression, but more so because of structural issues. How can you upload this by matching it to a fact you already know? Ask yourself, what is the rate of GNR bacteremia in patients with AIDS? Is it the thing you learn in medical school? No. The most common bacteremic syndrome in patients with HIV/AIDS is non-typhoidal salmonella. Non-typhoidal salmonella does not live in your GI tract. It's an exogenous foodborne organism, re-illustrating that core concept. All this rambling to say that you cannot rest comfortably in thinking that her immunosuppression is driving her bacteremia from the GI tract. That area that we know is an area of vulnerability on our CT scan is likely acting up. And the reason I'm so fixated on that area is whenever you're trying to figure out reticuloendothelial activation, which Prof. Rez will analyze, it's really important to track the area of asymmetry. This morning, our internal academy case was a case of a patient who had a hint of reticuloendothelial activation, not classic, but had a focus of asymmetry in his lungs. The lungs were the answer, and the spread was reticuloendothelial. So I really would be open to one of many possibilities, but the important possibility is that the ileum is the origin of her disease process. And the clues are the holes, microscopic, that it is poking, allowing E. coli to seep through, and potentially the spread into the reticuloendothelial space. But we should analyze that reticuloendothelial fingerprint with the data we have. And for that, let's get some Prof. Rez wisdom.
That was so well said, and I think that it's so easy to anchor on the E. coli and say case closed. And I'm really interested to know when the LDH was sent, because that LDH being sent may have saved this patient, recurrent hospitalizations and delays in diagnoses. And I think here, Rabih has really painted a picture that intestinal breach led to the E. coli, and that same intestinal breach has found its way through the bloodstream into the liver and the spleen. And so then the question is very simple here. It's what is causing that intestinal breach? And remember when we said we had that really high alk-phos? And it's so interesting. Look, that AST and ALT are totally normal, which is just super fascinating. But something's invading those caniculi, like we said, without causing much damage to the hepatocytes. And we said that, well, look, if we got an MRCP, there's no biliary dilatation. We're going to go after the liver unless there's something easier to access. And I think here, just knowing the sequence of events, that terminal ileum was where it was first the site of pathology before anything else. Now my question is, can we do a scope and just assess that area and, biopsy that area? The one question I would be asking the gastroenterologist is almost like a patient with diverticulitis where you don't want to scope them too early, where you might cause a puncture. Does the fact that we have E. coli and we think it's coming from the gut mean that site is not the best site to try to biopsy, because we already have a breach and we already have E. coli in the blood? And should we go after the liver? So I think for me, Rabih, I'm not even doing our whole schema of hepatosplenomegaly because we're this far in the case. I've already updated in my mind that this is something infiltrating. We have to understand what it is. We will send the EBV and CMV. I think that's very important in post-transplant patients. And the idea of post-transplant liver proliferative disorder is that it's highest in that first year. when you have, very strong immunosuppression. So the transplant was in 2021, so this would be quite far out. But I think you're going to send the HIV, the EBV, the CMV, and then the next most important step is to obtain tissue. And I think I would talk to the gastroenterology colleagues to see if a colonoscopy is a possibility, if it's safe. I would go that route. Some could argue that if you want to diagnose metastasis, go to the site that you think the tissue is spreading. So you can be one and done, meaning you obtain tissue and you talk about the staging of the malignancy. And that's not wrong either. So I would honestly just talk to oncology at this point and see what is the best site to biopsy. Because the question we're asking is what's the safest and what's the site that's most likely going to give us the answer. Here, it might be the liver. I think the liver is a really good site too, by the way. I really do. Or the colon. Any thoughts on that, Robbie? Which site?
No, I completely agree with you, Prof. Rez. I have nothing to add. I think this case is a reminder that we should have a low threshold to fully inventory every organ. And the only organs we haven't inventoried is going head to toe. We've inventoried the head with a good exam and a neuro exam. We've inventoried the extremities, we've inventoried the belly, and I think that a chest X-ray in a patient like this is not sufficient to inventory the chest. And so I think as you try to figure out which place to get data from, I agree with your analysis of the belly. I would be surprised based on the lack of respiratory symptoms in the clear X-ray, but I wouldn't be shocked if we had another data point to analyze about where to get tissue from if we scan her chest.
I love that. Well, this is how we first met, man. The Strange's case, which is in the book.
Yes.
Robbie was an intern. True story, guys. Let me just share this story real quick. I was a third-year resident, and there was a morning report, and it was a patient from somewhere in Southeast Asia who had E. coli bacteremia and had gastrointestinal symptoms. And then Robbie said, "Hey, can this be Strange's?" And I was like, I didn't know who Robbie was. I was like, who said that? That sounds like our program director, Harry Hollander, saying that. And then the chief president was like, Robbie, tell us a little more. He's like, yeah, well, if you get Strange's, hyperinfection, you get a breach in the mucosa, and the E. coli can be the first clue of Strange's hyperinfection. And that's what the diagnosis ended up being. And I went up to him. I was like, hey, I'm Reza. What's your name? He's like, I'm Robbie. I'm an intern. It's the first week. Sorry, that it lands better in the book, but that's sort of how the event unfolded.
It lands better in the what, Prof?
In the book.
Okay, all right, cool.
Jazz. The book is titled Discipline of Diagnosis.
This is the most painful, slow release of a book ever.
But you know what? We're self-publishing, so no one can stop that book from being released.
All right, Lorenzo. Thank you for bearing with our humor despite having no sleep. We appreciate it. Mike, to you.
So, in terms of repeat labs, she had a worsening pancytopenia, now with an hemoglobin of 6, a leukocyte count of about 1,500, a platelet count of 84,000, and an hyperproliferative marrow with a retic count of 7, where the normal is between 25 and 100. Her fibrinogen was 3.5, which is normal. Her triglycerides were of 150, which were also normal, and her ferritin level was 6,500, which is elevated. Her folic acid level was 6, which is normal, and her B12 level was over 2,000. We did a peripheral smear that only showed pancytopenia with no particular features. We did a Coombs test that was weakly positive for C3D. We did an IgRA test, which was negative, and she had negative serologies for HIV, Hep B, and Hep C. The patient's overall state improved with fluids, prednisone, and antibiotics. Her CRP also improved, but only temporarily. After about a week, she started to then trend upward, the CRP, and she began to have fever again, with no signs of focality. Despite dialysis, the patient showed no signs of improving kidney function in between sessions, with creatinine always in a plateau around the 12 mark, and with a potassium always above 6. We did another set of blood cultures, which were positive for Enterococcus faecium, sensitive to vancomycin. The patient was then started on vancomycin, and the fever subsided, but her inflammatory markers remain elevated. And I'll stop here.
I think it's you, Prosperous. No, me?
Okay. Reflexively, when I saw this is such a Lorenzo, you are an expert presenter, my friend, and you sound like Rabih with no focality. You guys are the next generation is stronger than the current generation for sure. Especially if the current generation only golfs all the time. The next generation will bypass them very, very quickly. Reflexively, when I saw all this data, the two thoughts came to mind. One is like, could this be HLH? And I know that HLH is not an end diagnosis, right? It's a proximal diagnosis, meaning you have to figure out what's triggered the HLH. But when you say pancytopenia, hepatosplenomegaly, elevated ferritin, it's worth considering as a syndrome, but it doesn't really change much diagnostically in this patient because it wouldn't be idiopathic HLH. If it is HLH, it's going to be secondary to probably an underlying lymphoproliferative disorder, specifically lymphoma. I would be interested in the EBV status of this patient because that portends a higher risk for lymphoma in the patient who has been transplanted. But what we're starting to see is now Enterococcus is making its way, Enterococcus faecium. We had E. coli. What's in the gut? It's not a monomicrobial, it's polymicrobial. So I think the patient's gut is telling us, man, it's not healthy. Something has invaded, something has breached, and that's causing all of these bacteremias. And it goes back to our initial conversation that these patients who are immunosuppressed are at risk for multiple diagnoses at once, not a single factor, especially when you have one of the S's, a structural issue that can be the underpinning of what is evolving. I'm going to pass the mic to Rabih to take it home.
Yeah, I know, Professor. I have like bread and butter teaching to emphasize. I think this great case this case shows us that there are gram positives that come from the GI tract, and I think whenever you're thinking of somebody's really sick, to broaden your horizons for gram negative and anaerobes in the GI tract, and enterococcus is really important to think through that. And so I think that this is yet another reminder of that. And I think the question I'm asking myself is, of all the places in the bowel, is it the fact that it's the ileum a coincidence or a clue? The ileum happens to be the place of the richest lymphoid tissue. And when the accompanying clues about a gastrointestinal disease that appears to be aggressive is not liver mets, space-occupying liver mets, lung mets, local lymphadenopathy, the accompanying clues, I know there's chaos in the chat, so I'm ignoring it. And I know Jazz and Deborah are horribly misbehaving. Oh my gosh. But anytime those two are in the same room, it's chaos. I'll find out the details of the chaos in like 10 seconds. But to finish the thought, the rest of this picture is so strongly hematologic. Liver, spleen, and then maybe marrow, although the marrow may just be the spleen. That I think the fingerprint of an unusual hematological manifestation in the GI tract is definitely at the front of mind. And yeah, if you could do one thing, I think it would be tissue, as you said quite a while ago. And the onus of that, you start to feel that that's what's necessary when you see that there's evidence of massive cell destruction of the LDH. And how do you diagnose a condition featuring massive cellular destruction? Well, you often need to look at the cells themselves and stain them and figure out what they are. So I'm exactly in that space. And I think there are experts at figuring out what cells to get, but I think that's the core question. For me, I think it depends on ease of access. And gosh, a colonoscopy seems less morbid than a liver biopsy or spleen biopsy or bone marrow biopsy, but it may be more morbid given the holes that it is leaking. Yeah, and I think, of course, you mentioned some non-mass based diseases like strongy, but strongyloides does not explain the hepatomegaly, splenomegaly, and the cytopenia. So there's more to the story here. Alrighty, I will hand the mic to Lorenzo, and I will be 90% listening, 10% trying to figure out what this chaos in the chat is.
Wonderful discussion. Thank you, guys. Since the patient had hepatosplenomegaly and pancytopenia, just like you, we were worried that there was heavy reticular endothelial involvement. So we did a bone marrow and smear and a biopsy, which showed a normal sphere. Flow cytometry had no signs of clonality of B anti-lymphocytes. The biopsy showed slight decreased cellularity of the myeloid series and increase of the erythroid series, but no signs of cancer or clonality. We also sent the biopsy for cultures for atypical bacteria, mycobacteria, and fungi, which were negative. At this time, we pursued a PET scan, which showed hepatomegaly with homogeneous uptake of FDG, nonspecific diffuse osteomedullary activity in the axial skeleton of tenuous mild intensity, no other major changes. We also did a bone scan that showed no bone lesions, and we also sent alk phos isoforms to an exterior lab, which showed a severely increased bone alk phos, but there was no mention of other isoforms. We started to discuss the case with our colleagues from gastroenterology and general surgery. And the colleagues from general surgery thought that the mass didn't look neoplastic in origin, but more inflammatory. So they thought of, instead of doing a colonoscopy, to do an exploratory laparotomy and maybe a resection. And after that, the intraoperatory report described a large inflammatory mass of the ascending colon, adherent to the right told fascia with duodenum thickening, no secondary lesions or peritoneal effusion. And the patient was underwent a right hemicolectomy. And after this, it will be the final diagnosis. And I'll stop here.
Oh, Lorenzo, you have me riveted. I think it's amazing how bony disease can evade detection unless you actively look for it. And I think, um, yeah, the fact that there is activity on the PET scan is interesting. The fact that there is activity on the laboratory side of things is interesting. But the fact that there is no uptake on the bone scan is very, very intriguing. And struggling to reconcile that because my current mental model, which will definitely be influenced by this case, is that whenever there is tremendous blastic activity in the bones, alk phos is secreted, and the bone scan, the radionuclide bone scan uptakes the nuclear tracer because of how active the disease process is, and the fact that that's not happening is very, very interesting to me. And so, yeah, I think the principle is really played out that once you see such an invasive process in the GI tract, adhering and tethering, you know that that's not normal and that likely coalesces it the case. Uh, how you incorporate such a high bony alk phos with no uptake on the bone scan and some mild to moderate PET avidity I think will be a friction point for me for sure. So whenever I'm encountered in that space, I always ask for help, which will be the best help I can get from Prof. Rez, but also just take a moment to remind myself that if I find friction, there's really two simple possibilities. I either am making the assumption that this is all united, and there actually is friction because there should be friction because they're not linked or there's knowledge gap. And the reason I can't link them is either I don't know something or have forgotten something. And so I'm really curious how it pans out. But the next step, if I were on an island, were to get what the biopsy shows and then see if with that knowledge I can start to connect the dots. But my piece of advice for you all is if you're in the same position I'm in real life, first step, get help and then check yourself on the assumption that everything is linked. It may not be linked. Only after all that do you say, oh, I feel bad. I should have known. None of that stuff really belongs, honestly. So let's do the first step now with seeing what Prof. Rez thinks.
Yeah, this is intriguing. And Lorenzo, over what period of time did this happen? Was this patient in the hospital for like a month, 2 months? Like it seems like a very long hospitalization.
Around 3 weeks, I believe.
3 weeks. Wow. Okay. Yeah. So, Robbie, I'm right there with you. I think that um, I'm still prioritizing a metastatic disease process. And we often try to think of malignancy or bone lesions as either osteoblastic or osteolytic. And the prototypical example of osteolytic is myeloma. And example of osteoblastic is prostate cancer. I think those two exist on a spectrum, but a lot of cancers features both. This one seems to be favoring lytic. I'm still prioritizing a malignancy in that category. And if I had to prioritize a malignancy, it would be a lytic and something that is also invading the liver, because the liver is, even though the alk-phos, I don't think the alk-phos is only from the bone. I know we sent the isoforms. We have a GGT that's elevated. We have a PET scan that's positive. I think I would still be interested in going after a liver biopsy or a CT guided biopsy of the bone where we clearly have these lesions. The challenge with that is the patient already got a bone marrow. So I'd be curious if that ends up matching up to where we're seeing radiographic changes. So maybe it's not necessary to go after the bone again. But yeah, I'm just right now I have my infiltrative hat on and I'm thinking cancer. I mean, there are non-cancerous infiltrative processes from amyloid, sarcoid, IgG4, histiocytic disease. But of all those in this host, I'm worried about cancer. And I'm worried about, I'm still worried about a hematologic cancer, to be specific, more so than a solid cancer. And I think that LDH and everything has me going towards lymphoma. But it's from a place of not having enough knowledge that I say that. But I'm just curious to see how this case unfolds.
Amazing discussion. So after the resection of the right colon, the patient started to improve overall, with inflammatory markers trending downwards, with no new fevers or no new bacteremias. The patient remained on dialysis for approximately a month after removal of the mass, after which kidney function started to improve until her baseline creatinine of around 3.5 and suspended dialysis. The biopsy of the mass shows this prototypical image, if I'm so inclined to show. Okay.
As he's pulling up the image, by the way, I wouldn't biopsy anything until we have actually the biopsy results of the first mass. Let me just put that on the table.
Paparazzi is just biopsying the whole body.
I'm not the wild west here, Rabih.
I know, right?
So this is not the real image, but it's an approximation of it, and this is what we found in her colon. This is what we call Michaelis-Gutmann bodies, and this is very pathognomonic of a certain disease or condition called malakoplakia.
Wow.
And this is the final diagnosis, intestinal malakoplakia.
Oh my gosh. Oh, so cool. Yeah, Prof. Rez, go for it.
I'm sorry. It's so interesting. I actually wrote a paper on malakoplakia. And if you ask the question, how many times did that diagnosis come in my mind? Zero. In fact, I forgot the word malakoplakia until But yeah, I mean, at the end of the day, at least let me just share what I know about malakoplakia from my own experience. It was a patient who was having recurrent UTIs, and eventually, due to prostate cancer, and eventually developed a mass. And the mass wasn't malignant, and it was just a consequence of the recurrent inflammation that the patient was experiencing. So it was a mimic of malignancy. But I don't really, like on my illness script, have malakoplakia going everywhere. Very curious, Robbie, as someone who reads so many of these cases, it seems like something has jolted you.
Oh no, just the joy of
I'm
medicine.
using jolted because those are the languages I have to use in the book. So I want to know what has jolted you.
What book, Pro? Oh no, I can't do it a third time. Yeah, I jolted just from the joy of medicine. I think it's so cool. I can't wait to learn and read more about this myself. But I think the first place to start is with Lorenzo, who's probably thought about it a lot. And the questions on my mind are, did the resection of the mass cure the LDH, the liver, the spleen, the alk-phos, how we put it all together? So no, I don't. I'm just, the joy you're seeing is just the relighting of why I love this and love my job, but I don't have any wisdom to impart, and I'll use my ears and not my mouth. Mike to you, Lorenz.
Thank you very much for the wonderful discussion to the both of you and to everyone in the chat. Malakoplakia, it's not a very, very, very frequent diagnosis. On the other spectrum, it's actually very rare. And it's basically a type of defense mechanism of the body against certain infections, where macrophages try to engulf the bacteria, but they can't really oxidize them and destroy them completely. So it's more like it starts to try to form a granuloma, but it's not really. It's more of a mix of a granuloma and a histiocyte mass. And usually it leads to cancer or pseudotumor like lesions. It's most commonly described in the bladder and in the kidney. It's usually more common in immunosuppressed patients, whether they have transplant, whether they have autoimmune diseases or HIV. And it has been described in a myriad of organs, in the tongue, in the skin, in the scalp, in the lungs, um, any place you can think of, in the bone marrow. There's a case reported for it. Usually what we do for it is try to attack it with antibiotics that can penetrate the macrophages. Quinolones, sulfamethoxazole, and trimethoprim. Those are some of the examples. And usually the patients get better really well with antibiotic treatment and with resection of the masses. This is usually a benign disease. In this patient with her heavy immunosuppression, heavy recent immunosuppression, she was really predisposed to develop this. And that's all I can say. The tension points we had was the same as yours, whether the alk-phos was due to this, due to a liver problem, due to a bony problem. And in my reflections, what I think, there's no obvious explanation here, but what I think it happened was either an HLH type picture where the heavy inflammation in the caused the cytopenias, caused the liver enlargement, the spleen enlargement, and caused the alk-phos. And that doesn't really jive with the alk-phos isoform tests we did. Although they didn't report all the isoforms, only the bony isoform, and that really didn't also correlate with the findings of the bone, all of the bone tests we did. Or there's other isoforms of alk-phos, and another one that we usually don't test, it's the intestinal one. And since this resolved with resection of the mass, either it was alk-phos of intestinal or colon origin or liver origin. And that's all I have to say. Thank you very much.
Lorenzo, I imagine people have questions for you. But I unfortunately have to rush to work. I'm a little late already. I'm just curious to ask you one question, though I know I can ask you on WhatsApp, but I imagine everybody's thinking about it. Do we know what happened to the site of like did all these things go away with the resection? Everything, liver, spleen, or was there a remnant of another feature somewhere else?
Everything got better.
Oh my
Alk-phos
God.
went back to 130, which was our previous level. Our
Crazy.
cytopenias trended upward. The only one that was really down, but we think it's due to our immunosuppression, was
Right.
the leukocyte count, which was around 2,000, 3,000. Hemoglobin trended upwards around 12, and platelets also got around 200,000. And our LDH also normalized, essentially.
My only request of you, Lorenzo, was a case simpler than paraneoplastic CMML. I think that was a simple ask, but I think you failed miserably. This is way more complicated and way more fascinating. And yeah, I don't know where to think, but I think you can title this case, if you ever choose to publish it, How the Surgeon Cured Pancytopenia. And I think no surgeon has ever cured pancytopenia in their life before. But by taking out that mass, the marrow made has just unbelievable to me. Anyway, Prof Rez, Mike to you. I'm gonna lurk here while I pack up my stuff, but I'm curious what everybody has to say.
I just want to show gratitude to Lorenzo. Lorenzo, that was such an epic hour. And I'm just so happy for this patient. Like, I know we're discussing this, in a virtual format, but this is someone's life. And the fact that it doesn't end with death and lymphoma just has me so happy for the day. And yeah, and I think it was just so expertly presented and the way you thought about it. And yeah, just so happy for this patient and looking forward to the teaching points. There's so many teaching points on the board. I'm just going to shut up and listen now.
What a fantastic case. I'm going to keep the teaching points short, even though there was so much learning from it and so much to reflect. So in this patient, the approach to diarrhea in an immunocompromised patient would be pretty much the same as an immunocompetent in cases where you have a common problem like diarrhea. And it would change the calculus only in patients who are critically ill or those where we're suspecting an evolving problem. And here the patient met the SIRS criteria and also met criteria for dialysis. So here the most important thing that we come across is the alarming LDH and ALP, which could be either due to a bone issue or a liver issue. So bypassing the infarction, if we think about LDH, it's important to think about malignancy like PTLD, where raised ALP would be because of infiltration to the bone hepatobiliary system or the bone marrow. So it's important to get imaging, even though it might be sneaky if it's infiltrating the intrahepatic biliary canaliculi. So it's prudent to get a PET, which was positive in this case. And we also had a discussion about E. coli bacteremia, where having an LDH of 2000 would not be explained by it. And this patient had a nidus of vulnerability in her GI system. And bacteremia from an infectious etiology is extremely rare unless it's a foodborne organism. And in this case, there might have been a microscopic breach. We discussed how E. coli could seep through the GI system and spread into the reticuloendothelial system. So we were wondering what was causing the breach that is destroying the canaliculi without invading the hepatobiliary hepatocytes. So the friction point here was there was tremendous blastic activity and increased ALP, but the radionucleotide scan did not pick it up. So it was important to think of metastatic bone lesions and also infiltrative conditions. So we found out that the patient had Michaelis-Guttman bodies, which is seen in the intestine, although the common one is seen in the bladder. And here the defense mechanism of the body was weakened, and that predisposed the patient to form granulomas, where the macrophages try to digest the bacterial infection, but it forms granulomas or pseudotumors instead. And it's important to use antibiotics like TMP-SMX that might treat it, but in this case we saw that surgery cured the pancytopenia at the end of the day. And also some fun facts that we got to learn for an RLR excerpt before the release of the book. How Prof. Reza and Dr. Rabih met was E. coli being the first clue to a strongy hyperinfection that leads to a breach in mucosa. And those are my teaching points.
Manaswi, what an incredible job. Thanks for keeping up with us. There was just so much information. Not only what you wrote on the board, but what you decided to articulate. It was phenomenal. I think, Lorenzo, you earned the right to sign us out today, my friend, with this case. So please, however you want to sign us out, just don't mess it up. The YouTube audience, they're very, very mean, and they'll yell at you. I know this from personal experience.
Oh, thank you everyone for coming here and hear us talk about a little bit of medicine, and let's keep on learning every day and more. Thank you.